Today we're very fortunate to have Dr. Al Poling with us. Dr. Poling is a professor of psychology at Western Michigan University. He is a prolific author, written a number of books, multiple articles, lots of presentations, and his work has been acknowledged in multiple ways, including an upcoming award from the California Association for Behavior Analysis for Lifetime Achievement, and also an upcoming award from SABA for translational research. So welcome, Al. Very happy to have you with us. And the topic we're going to talk about today is the use of psychotropic medications in the treatment of behaviors for children and adults on the autism spectrum. So maybe, Al, if you could start off by giving us a little orientation as to what is the rationale for using medications to treat some of these behavioral problems? And in particular, if you'd like to give us an update on what we know about the kind of neurological or biological causes of autism, because that, if I'm not mistaken, that's probably some of the rationale for the use of psychotropic medications.
Well, thanks, Wayne, for giving me the chance to talk about psychotropic drugs. I wish it were the case that the medications that are currently used are based on our understanding of brain structure and function as it relates to autism, but that's not the case. Recently, people have learned a lot about how the brains of people diagnosed with autism spectrum disorders differ from the brains of people not so diagnosed. And that knowledge may eventually lead to the development of effective behavior change medications. But to this point, the medications aren't based on an understanding of the etiology of autism. Really, they're simply used because they, in some cases, reduce troublesome behaviors. So it's just an empirical phenomenon. And that's as much as there is at this point.
Okay, so in reality, we aren't using drugs to cure anything in the traditional sense of the word. We're using it to treat some of the behavioral symptoms that are associated with autism.
Absolutely.
Okay. So if I understand correctly, Al, then what we're using psychotropic medications to treat some of the behavioral symptoms associated with autism diagnosis. Can you talk a little bit about the types of behavioral symptoms that we might be interested in treating? And then we'll probably want to segue into talking about the types of drugs and the pros and cons of the types of drugs that are used.
Well, ideally, we would have drugs that ameliorated the three core characteristics of autism, the impaired communication, impaired social interactions, and the restricted behavioral repertoire. And people are hoping to develop drugs that are effective in one or more of those realms. But at this point, the drugs are used really for one purpose, and that's to reduce inappropriate responses. There are two drugs currently approved for treating irritability in children and adolescents with autism between 6 and 16 years of age. And those drugs are risperidone, Risperdal, and aripiprazole, Abilify. And they're not used to treat autism, but to treat irritability. And irritability comprises a range of undesired behaviors, temper tantrums, self-injury, verbal and physical aggression directed at others. So really, the drugs are used to drive down inappropriate responses.
It seems like an appropriate use of medication, but just to clarify, a lot of what we're talking about with the signature symptomatology of autism is really behavioral deficits. Communication, for example, socializing, restricted range of interest, that sort of thing. And the drugs aren't being used to treat those core symptoms, if I understand correctly.
They aren't being used effectively for that purpose. If you look at the research literature, there's good evidence that a number of different drugs are useful in reducing troublesome behaviors in many, not all, but many people diagnosed with autism. But there's very little evidence of strengthening of desired repertoires.
Just as a result of the medication, though.
Of the medication, yeah.
Interesting, okay. I hear a lot about the use of medication. Is it something that's fairly commonly used in this population now?
It's almost ubiquitous. There have been a number of studies that have looked at the prevalence of psychotropic drug use, and of course results vary across studies, but you typically see something in the neighborhood of 50 to 70% of people with autism receiving at least one psychotropic medication, and somewhere between 20 and 40% receiving two or more. So the drugs are widely used.
So very widely used, and
Yeah, more commonly used in males than in females. And if there's a concurrent psychiatric diagnosis, then that also increases the probability. But even in girls and people with no comorbidity, the use is widespread.
yeah. And does that concern you at all about the level of prevalence for the use of medication? I mean, my sympathies go out to people that are struggling with the behavioral problems of autism, and they go to a physician, and I'm supposing that that's the most effective available medical treatment that they're adopting, essentially.
Well, it concerns me in that I think all good treatments are evidence-based. And when one looks at the evidence supporting the use of various psychotropic medications, it's not compelling in many cases. So that concerns me. And also, when individual people with autism receive these medications, typically the evaluation of effectiveness is slipshod at best. And for me, evidence-based practice has two components. First, you implement an intervention that has been shown in good scientific studies to be generally valuable and tolerable, no serious untoward effects. But then second, when you use that treatment with an individual, you make sure that the trip justifies the fare, that you're actually helping that person.
Right.
And I think the psychotropic medications are often used in the absence of good scientific evidence, and moreover, in the absence of good day-to-day evaluation of effects. So I do have some concerns.
That's a very helpful model to think along the lines of evidence base, as having at least two components, including the individualized clinical assessment of progress or response, for example, to a medication or treatment. Let's come back to that one a little later on. Let me get you to talk a little bit about the type of scientific evidence that's out there to support psychotropic medications. You mentioned that there are a couple, Risperidol and I believe Abilify, trade names,
Yeah.
or brand names, excuse me. How good is the research along those lines, and what else is out there that people should be aware of and possibly concerned about? My impression is that a lot of things beyond those two are also prescribed.
Oh, yeah, dozens of other medications are at least sometimes prescribed. With respect to risperidone and aripiprazole, they're FDA approved. So the quality of the evidence that was provided was deemed by experts to be adequate to justify the use of those drugs. So those drugs for that application have met the same standards of evidence that other medications that are in the pharmacopoeia meet.
Right.
Now, how good are those studies? Well, it depends. There are some common problems in this literature. One is that the studies are almost inevitably short-term studies, weeks or at most a few months. And the studies that led to FDA approval of the two drugs in question were relatively short-term. So that's a problem. In many of the studies, outcome measures are weak. People often use rating scales, very little direct measurement of behavior, so that's a characteristic problem. Assessment of untoward effects is often inadequate. Not always. I don't want to damn all the studies, but many of them are weak in that regard. People don't look at medication interactions. There are essentially no studies of polypharmacy in autism, although it's quite common. So that's a problem. With untoward effects, they often emerge slowly. So if you do a study that spans 2 months, you may well miss untoward effects that emerge later on. That's a problem. So there are lots of methodological weaknesses.
Yeah, so it sounds like that the short-term aspect of the study has multiple concerns about it. One of them is how long do the effects last, and also are you detecting side effects that might emerge over a protracted period of administration?
Right.
Okay, that sounds interesting. Let me ask another related question to that in terms of the way the studies are put together. Are the behavioral effects of the two drugs that you're talking about that are FDA approved, are they unique to autism or are they generic? Would they have similar effects on the behavior of anybody regardless of diagnosis? In other words, is it a more general behavioral suppression mechanism that's going on, or is it something specific?
My guess, and there haven't been good head-to-head comparisons, but my surmise is the effects aren't unique to autism. There's nothing in the mechanism of action of these drugs that would suggest that the effects are unique to people with autism. In fact, they're both categorized as atypical antipsychotic drugs.
Okay.
So they would produce a similar profile of effects in people diagnosed with schizophrenia and related conditions, and that's why they're used.
Okay. Can you talk about the clinical indications for the use of the drugs and how much impact on behavior might occur? I know that you have reservations about the quality of the research, but a person comes into a pediatrician's office and they're having serious temper tantrums and aggression with a child. How much effect and how quick of an effect might the drugs produce on some of those, and how do you then justify its, or at least evaluate its use for a child?
Well, if you look at the literature, in many individuals, you get a substantial effect, an effect that is probably clinically significant.
Fairly quickly.
Fairly quickly, yeah, within 2-3 weeks. I mean, it takes a while for these drugs to produce an effect, but it wouldn't be unusual to see a noteworthy, important reduction in inappropriate behavior within a month, let's say. So that's the outcome that people desire, and that's why these drugs are used. Moreover, they're relatively inexpensive compared to some alternative treatments. They're easy, and they're really about all a physician has to offer. And in saying that, I'm not disparaging physicians, but when it comes to changing behavior, they can give you advice, they can give you drugs, and they might give you a reference to some other sort of an intervention specialist. But if they themselves provide treatment, as we inevitably ask them to do, well, drugs are the only game in town.
Yeah. And that's what people go to physicians expecting typically.
Exactly.
Some sort of a effective intervention or an explanation or some way to resolve or improve this problem that they're having. And it sounds like that is probably one of the chief things that's in their armamentarium of interventions, essentially.
Yeah, I mean, it certainly is. And moreover, if they look at the literature, with many different drugs, there is evidence of effectiveness. So, I mean, they're often using evidence-based practices. Now, we could debate the quality of the evidence, but it's as good as there is for anything else that's available to a physician.
So I detect that you have some reservations about the use of psychotropic medications. For clarity, is your concern mainly about the quality of the evidence out there, or is it mostly about the potential for side effects emerging, or is it that it doesn't really solve the fundamental problems? Help us understand what the nature of your reservations are here.
Well, my concern would be in all three areas. Okay. With some drugs, and there's so many drugs used that we really can't talk meaningfully about various individual drugs, but with some drugs, there's almost no evidence, or the evidence is so compromised that you can't make anything of it. So that can be an issue. But many of these drugs they don't always, but they can produce significant untoward effects. Some are irreversible. So, that's a concern. And you never develop new behaviors as a function of taking drugs. Drugs don't teach people anything. And everyone needs to develop a repertoire over the course of their lives. And when we're using medications as our primary tool to help young people with autism, well, we're not focusing on teaching them adaptive repertoires.
Yeah. So that's an especially good point from my perspective. And does it suggest that if you do use medications to handle some of the, let's call it irritability problems, that it would be best practice to consider adding it combined with some effective repertoire building interventions, such as applied behavior analysis based interventions?
Sure, yeah, inevitably. I mean, it's never enough to drive down an inappropriate behavior. We always want to build in some replacement, and medications aren't going to do that. I think we also should consider alternatives to pharmacological interventions, because there are sometimes options that don't have the same profile of untoward effects. But it's hard to compare alternative interventions. Think about risperidone. It's approved for treating irritability. Well, we know that there are a lot of behavior analytic techniques that will also reduce inappropriate behaviors, tantrums, self-injury, aggression, so forth. But if you look at the literature, there are no comparisons of risperidone and behavior analytic treatments, no head-to-head comparisons, not one. But there are separate literatures, right? Mm-hmm. So if you want to be informed, and you have the wherewithal to understand scientific literature, you read what there is about risperidone as it's used to treat, quote, irritability. Mm-hmm. And you read what's known about various behavioral interventions for similar applications. You try to compare it. Well, it's an apples and oranges comparison. Different kinds of outcome measures. The behavior analytic stuff, it's within subject designs with 2, 3, 4 participants, direct measures of behavior most often, social validation measures. You look at the clinical psychopharm literature, group studies, right? Means reported statistical analyses, indirect measures of behavior like the aberrant behavior checklist. So how do you compare that? I can't.
Yeah. So I find it remarkable that there aren't head-to-head comparisons, because what you have to do as a practitioner, be you a physician or a BCBA behavior analyst, is you have to make decisions about the best available practices.
You do.
And it would be nice to have that informed by direct comparisons, essentially. And in saying that, I want to make sure everybody understands that I'm not suggesting that the BCBA would ever be involved in prescribing medication, right. But it helps to have this direct comparison to be able to decide, well, what is the most efficacious strategy and with the fewest side effects and the best long-term outcomes, these medications or behavioral procedures. And in some ways, what you're describing is almost two silos, independent level areas of research that physicians know this one, BCBAs know this one, and the twain is a null set, essentially.
Yeah, no, I think you're exactly right in that. And moreover, people discount the other area of research. Mm-hmm. Like behavior analysts say, well, all that medical research is garbage, and medical people say all the single case work is garbage. And I think ideally we would have treatment teams that can translate one to another, but that's easy to say, it's hard to do. Yeah. And it's hard to do the psychopharmacological research. It's easy to disparage work other people have done, but it's hard to do clinical drug studies in protected populations. And then if you add in a comparison to a behavior analytic intervention, and then ideally, a third condition where you look at an interaction, well, we can design those studies, but can we arrange to do them? Probably not.
Yeah. Sounds like a challenging situation, and I'm not sure that will be remedied anytime very soon.
Don't have much hope of it.
Yeah. So it sounds like we're in a situation where we're going to continue to see medications prescribed for autism, and then you're going to continue to see BCBAs doing applied behavior analysis interventions for autism. Can I loop back just for a second? You mentioned 2 drugs that were FDA approved.
Right.
Would you give us a sense of the other range of drugs, Al, and in particular whether there's any ones that look promising, or any of them that you have specific concerns about? Because my sense is there's a pretty good pharmacopoeia out there that's sometimes used with autism.
Yeah, it's a huge range, Wayne. Almost any drug class that you can think of is at least occasionally used with people with autism. The most used group of drugs are the antipsychotic drugs. The atypical drugs are used, but also the older typical drugs. There's some evidence that haloperidol, Haldol, is of some value. One reason that there's some evidence of that is that there are several studies of haloperidol relative to many of the other drugs. The antipsychotic drugs are commonly used. You see some use of various antidepressant drugs, especially if you have evidence of comorbidity. Now, autism isn't protective in any sense. It's not a prophylaxis. You can be diagnosed with autism and be depressed and be anxious and be any of the other things that people can be. So whenever there's evidence of comorbidity, even if it's weak evidence, typically you would have a drug prescribed, or often you would have a drug prescribed to deal with that comorbid condition. And there's no reason to believe that those drugs would be more or less effective in dealing with those conditions in people with autism than in other people. But of course, that raises the big issue of, well, how well do they deal with problems in other populations? You know, if you think about antidepressant medications, for the past 15 years, there's been a big brouhaha about whether those drugs do more harm than good. You know, and some people have contended, well, they may irreversibly alter brain function so that things get worse in the long run. Other people argue to the contrary. But those same arguments would pertain to people with autism. And in many cases, there just isn't an adequate research base to say anything. You know, some people advocate the use of oxytocin to treat people with autism. Well, if you look at the studies, you know, there's not much, and you just really can't say anything. Stimulant drugs aren't used very much. They don't seem all that beneficial, but often the literature is inconsistent. You know, one study shows some benefit, another not so much. So it's really hard to reach conclusions.
You know, I find it interesting and a little bit troubling that there's so little research out there on the efficacy of these drugs with autism or with the autism population. But at least the drugs you're describing have been through some sort of FDA approval process. Is that correct?
Right, they have, yeah.
So we know something about their mechanisms of action and potential side effects and stuff. Yeah. Do you also have concerns about other chemical and biological interventions that are not FDA approved? I mean, it's just, I find it amazing how many what you might call fad treatments are out there. Everything ranging from people suggesting that marijuana oils or gluten-free diets or some sort of miracle mineral water with, you know, chlorine dioxide in is going to solve all the problems for a child. Do you have concerns about those also, Al, or similar nature, or worse?
Yeah, essentially the same kinds of concerns. You know, is there any evidence that these things will work? Are they being monitored on a case-by-case basis? Is there a possibility they'll do harm? And also, do they have substantial opportunity costs? One nice thing about pharmacotherapy is it's easy. You know, it doesn't take up a lot of a patient's time, and so they're not engaging in activities that are costly. But with some of the other fad treatments, you know, they require quite a bit of effort on the part of the patient or on the caregivers of the patient. So their opportunity cost becomes a big issue.
And by that you mean that they're engaged so much time and effort that the opportunities to pursue other types of treatment may be curtailed, right?
Exactly.
Right, okay. Yeah.
Exactly so. And of course, with any intervention, you have to consider whether it might compromise sensitivity. to everyday learning opportunities or to specific treatments. You know, we know, for instance, with the psychotropic drugs, well, some of them can produce a cognitive blunting, so people just don't learn as well. Now, you can't say that this is a universal effect of any drug, and certainly not of all drugs, but it can happen. And it's very hard to sort out whether being exposed to a medication or some other biological intervention alters sensitivity to, say, behavior analytic interventions. And the alteration wouldn't necessarily be bad. You know, sometimes, for instance, a drug might be highly useful if it drives down inappropriate behavior so that the person can come under the control of consequences. So, you know, in saying that a medication or another intervention might alter sensitivity, that doesn't necessarily imply that the alteration is bad, but it can be. And that's something we don't study.
Well, I was going to ask if we had enough research to be able to predict which ones would have a beneficial interaction with behavioral interventions versus a detrimental interaction with behavioral interventions. Do we have any sense of guidance on that, Al?
No. I mean, you know, now and then there's a suggestion, but it would be peripheral. There aren't any good data in people with autism to show that a particular drug sensitizes people to a particular kind of behavior analytic intervention or desensitizes them. We know some drugs have motivational effects, you know, and that could well play into it.
Can you give us an example of motivational effects, maybe, Al?
Yeah, not in people with autism, but again, I don't think there's anything unique about that population with respect to the motivational properties of drugs. John Northup down in Louisiana has done some good work looking at the effects of stimulant drugs in people diagnosed with ADHD, young people, and he's found that, unsurprisingly perhaps, stimulant drugs decrease the reinforcing effectiveness of edibles and increase the reinforcing effectiveness of social interactions. Now, you know, is the effect big enough to be of practical significance? You know, who knows, but I mean, he has nice data.
Yeah. Well, you know, that would be an important bit of information, and I know that's not an uncommon prescription for a child on the autism spectrum is to have some of the stimulant medications because sometimes it's comorbid with ADHD symptomatology. Yeah. But it would be important to know that if, for example, you were relying on edibles as one of your interventions in an ABA program, it might greatly decrease the efficacy of that. But on the contrast, it might increase the effects of social interaction. Yeah. So that would be a very helpful thing for a BCBA to know something about.
You know, it's interesting, the last point you made, since social interactions are often not that reinforcing in people diagnosed with autism, maybe you wouldn't get the same enhancement. You know, I don't, no one's looked at that to my knowledge. But if you did, that would be sweet.
That would be very interesting to know, actually. Yeah.
Yeah, it would.
So that's an example there where obviously there's a potential interaction with a behavioral intervention. Naively put, let me paint this scenario. You have difficulty doing a behavioral intervention because the child's engaging in tantrums and aggressive behavior and a number of other disruptive behaviors. Is that a good rationale for saying, well, let's see if we could use some of the medications that have proven to have an effect on, in great big quotes, irritability? So. Would that make it a little easier to do the behavioral interventions and perhaps increase their efficacy, their impact?
Well, one would certainly think so. You know, I mean, you'd have to sort it out on a case-by-case basis, but I think that would be a good justification for a short-term drug trial. You know, and if it worked, great. You know, then you could ostensibly withdraw the drug, and so you don't have to worry about any long-term untoward effects. Have the behavior under control. You know, it might be a quite nice application of combined interventions.
Now, it's important to note that you said short-term as opposed to using drugs as a long-term management and treatment strategy. Yeah. Is that kind of the best practice model that you would recommend here? Is that if you're going to use the drugs, use them on a short-term basis to allow you to work with behavioral interventions and then figure out a way to withdraw them when you can?
Well, I think in many cases, not all, I'm convinced that there are boys, girls, men, women, with and without a diagnosis of autism, who benefit from essentially lifelong exposure to psychotropic drugs. I don't think that there are huge numbers of such people, but I am convinced there are some. And of course, the issue is isolating those people. Good clinical intervention, regardless of modality, matches people to treatments. And what we need to know is which people with autism are going to benefit from long-term drug treatment and with what drugs. But we can't do that now.
Yeah, so it sounds like we have a ways to go with our research space, don't we, Al?
Well, I think one thing that happens is a drug's prescribed, you see improvement with respect to reductions in inappropriate responses, and that's taken as a justification for continuation of drug treatment. And if the drugs were innocuous, then that would be fine. But these drugs inevitably perturb brain function. They don't right wrongs necessarily. A lot of people think, well, psychotropic medications correct known imbalances. Like in type 1 diabetes, right? You don't produce insulin, so you take insulin and everything's more or less normal. Well, that's not the case with psychotropic medications. I mentioned earlier that the drugs that are now used don't really address the deficiencies, the differences that we see in the brains of people with autism. But they do perturb brain function. And some of the perturbations are enduring, and so you're going to get an altered person. And the alterations may not be to the person's benefit. So I think in clinical psychopharmacology, less is always more. You should use the lowest dose that produces benefit, and you should use that dose for the shortest period possible. But in pursuing that goal, you want to make sure you don't deprive a person of a medication from which she or he derives significant benefit. So it's a real balancing act.
The follow-up is the question where I wanted to loop back to, I guess, and that is that when you talked earlier about evidence-based practice, the importance of doing individualized clinical assessment of reactions to medications and stuff. Is that one of the places that the BCBAs should be actively involved with physicians and with who administer medication on the autism spectrum? And what role do you see the BCBAs having in terms of helping to kind of monitor individualized response?
Well, I think that's a place where behavior analysts could be invaluable. It's interesting, I've been talking about drug effects in people with developmental disabilities for a long while, and it's not unusual for a parent or other caregiver to approach me and say, my son or daughter is taking this drug or these drugs, and do you think that that's okay? And I always say, well, I don't know. Is it helping? What's it supposed to do? And often the person says, well, I don't know if it's helping because it's supposed to make her or him better. And I don't know if they're better. Well, of course, the obvious question is, what do you mean by better? And ideally, when a physician was considering a drug trial, it would be great if a team of people sat down and said, okay, if this drug works, what exactly will it do? How will the patient change behaviorally? And what are the measures we could take to index that? And behavior analysts are good at measuring behavior. I mean, we can define target responses and we can measure target responses. Now, in the everyday world, you can't do that as well as you can in a research setting, but good enough, certainly better than nothing. So I think if one had a situation where a physician was willing to work with a behavior analyst to develop a drug assessment plan, that would be great. And sometimes that happens. But physicians inevitably are incredibly busy, and so they don't have a lot of time to sit down with a treatment team. Moreover, somebody has to pay them when they do that. And insurance companies are not real keen on paying for that sort of thing. But that would be the model I'd like to see us move toward, Physicians are really good at monitoring physiological effects, picking up untoward effects. If blood pressure is going down or going up or whatever, they can pick that up. But measuring behavior, that's not their strong suit.
Right. And that's where perhaps you're saying a collaboration with the BCBA might be helpful. And I'm kind of imagining a model where you identified a concern, a behavior of concern, let's say aggression or frequency of tantrums or something. And as part of the medication protocol, the BCBA knows when the medication is being implemented, has a baseline measure of those problem behaviors, and is able to track and monitor changes over time of those target behaviors. And in theory, would they then try to get that information back to the physician?
Sure, feed it back, exactly. Feed it back to the physician. Yeah. Feed it back in a user-friendly way. And talk with the physician up front about how they'd like to see the data, and that's ideal. And sometimes that happens. I've talked to some behavior analysts who work with psychiatrists, and they work hand in glove. And one thing that often happens there is the prevalence of drug use goes down. Because people see, well, the medication's really not doing what we'd like it to do, no point in having it. But when medications are used, then they're used to the benefit of patients. And of course, that's the key point. You want medications, like all other interventions, to benefit the patients, not necessarily to benefit anybody else. And it's so easy to think drugs are doing wondrous things if undesired behaviors are quelled. And you don't necessarily ask, well, what's going to happen in the long run? What's the cost of this? If a person's quiescent, well, they're not a problem. And of course, years ago, there was a lot of interest in the effects of psychotropic drugs in people with mental retardation. And it became clear that often, not always, but often the drugs were used as chemical straitjackets. They would certainly drive down inappropriate behavior, but they drove down everything else. And we don't want that to happen again. But sometimes it does.
So that suggests then you need to look not only at the, let's say, the positive symptoms that you're monitoring, but you probably, if you're a BCBA, you want to be looking at the effects on acquisition of more appropriate replacement behaviors in addition to monitoring.
Yeah, and just, and day-to-day performances of desired behaviors. And of course, again, it's easy to say that, but if you think about young people, well, their repertoire is constantly changing, right? So it's hard to sort out, well, what's a drug doing to rate of change? Because you don't have a baseline.
That's a good point. Yeah, and then on top of that, I would imagine, now you're talking about, well, you don't have a baseline, you got a constantly changing repertoire. It must be hard to attribute behavior change to drugs sometimes, the addition of a prescription, for the reason you talked about, and also because I would imagine that at the same time the medications are being administered, there's probably active behavioral programming as well as natural learning that goes on that shapes our behavior over time.
Yeah, in everyday events, the miracles and the tragedies that are just part of life, and they can change behavior dramatically. So, it's hard to do adequate drug evaluation. But I think it behooves us to do the best we can.
Right. Now, related to that, let me ask another question. This has to do with also what you might call the limits of the scope of practice for a BCBA. What we just described, where you're saying, let's take a baseline, let's then work with a physician to get the drug administered and see what impact it has on the challenging behaviors and the acquisition side of things. And a lot of BCBAs are very familiar with reversal designs as one of the ways to rule out confounding variables. And there's a lot of things that are confounded with the administration of medication.
Sure.
Do you ever see people collaborating to do some sort of a medication withdrawal phase? Once again, I mentioned the scope of practice because this is not something that BCBA is authorized to do. This is a physician's role is to prescribe and take away prescription and do a drug trial like that, but the BCBA would be in a collaborating role?
Yeah, and I think a hugely important collaborative role, but in a support role. And we always have to recognize that. This is an intervention we can't control unless we're MDs. But we can perhaps benefit the people who are prescribing. And I'm convinced that physicians want to use these drugs to benefit people with autism. They aren't bad people. They aren't charlatans. They're doing the best they can. So we can team with them. And I have seen many cases where behavior analysts have helped physicians to evaluate drugs during a withdrawal period. But this business of withdrawal is more complicated than it might seem, because if you take away a drug precipitously, well, you're often going to upset the apple cart. So there has to be a downward titration, and many physicians would know how to do that, but some maybe wouldn't be so good at it, and it needs to be very gradual. And moreover, if you simply move from a drug condition to a no drug condition, then you have a real possibility of bias affecting results. If you think about it, we see what we want to see, do we not? And confirmation bias is ubiquitous. So if you have a team of people providing data who believe that the drug is or is not effective, and they know whether the drug's present or absent, that might affect their data. Not that they're cheating intentionally, but for instance, an instrument that's commonly used to evaluate psychotropic drugs in people with autism is the aberrant behavior checklist. It was developed back in the 80s to evaluate drugs in people with mental retardation, and it's 58 items. And they're just simple statements like intentionally injure self. And then a person familiar with the individual in question assigns a score. 0 is not a problem, 4 is a severe problem, and then 2 or 3 are intermediates. And it's a reasonable scale. It's easy. It has decent psychometric characteristics. But you can imagine how expectations could affect your score, right? So I know she's off drugs. Well, that's more a problem or less a problem. So you should have a placebo control. Well, it's easy to say. But in the everyday world, who makes the placebo, right? Who pays for the placebo? So it's not necessarily easy to do a good drug withdrawal. And also, you have to carry out that period of withdrawal long enough for any effects of drug withdrawal per se to wash out. Because that drug's doing something to the brain. Well, you take it away, the brain's returning to some extent to the unperturbed state. Well, you're going to get changes in behavior. On the other hand, if you start to withdraw a drug and behavior deteriorates, it may eventually get better, right? But how long do you wait? Because some people are so enthusiastic about drug withdrawal, they basically repeatedly disrupt fairly stable performance by attempting drug withdrawals. At some point, and I don't know when, you need to say, hey, this person does better on drug than off drug. And so endless attempts at withdrawal probably don't amount to anything except harm.
Does that suggest that a limit on the role of BCBAs in doing this sort of things, or just some cautionary notes to be aware of potential for bias regarding confirmation bias, concerns about transient effects of withdrawal over a period of time?
Yeah, I think it's...
So these are methodological concerns that you would want people to at least be sensitive to, it sounds like.
Yeah, and it doesn't matter whether, it's the behavior analyst who is sensitive to these things or some other team member, but someone needs to be aware of these things so you're not really misguided by your findings. But again, I'll make a point that is important. Any attempt at evaluation is better than no attempt, because so often if you look at how drug regimens are evaluated and titrated, it's management by anecdote. Something really bad happens and the dose is adjusted upward, usually, or another drug is added. It's just one incident, regardless of causal variables. And that's a bad way to manage anything.
Yeah, especially when you are dealing with potential for side effects. And that's one thing we haven't talked much about yet. We talked about the role of the BCBA and helping monitor the main effects of a
Yeah.
drug, and also made the argument, which I think is a great argument, about let's look at acquisition also, because you don't want to just focus on the management of the challenging behaviors. But as you pointed out earlier, Al, so many of these drugs have side effects, many of which are behavioral in nature. That seems like such a broad palette of things that you might have to monitor. Do you have any advice for the BCBA who's interested in doing some of this clinical evaluation about what do you look for in side effects? Do you go to the PDR and say, what do they recommend you look for? Or how do you be sensitive to side effects, Al?
You could certainly do that, but if you look at the PDR, typically they're going to be physiological side effects. And of course, behavior analysts can help to pick those up. If they talk about behavioral effects, they're often described so generally that it's hard to know what exactly is the issue. But I think certainly there are some things that are fairly easy to measure that might be important. Sleep patterns, just attention would be one thing. Performance on repetitive daily tasks. If there's something that people do all the time, well, does your performance change? Sociability. Are these people seeking out contacts more or less than usual? Those would be some things. And I think any behaviors that are particularly important for the person in question. If you're working on a particular target behavior, well, how is that changing? So those would be some things. And of course, you'd have to look at the drug in question always.
Yeah. So it sounds like if you're going to be collaborating with a physician, as a BCBA, you got multiple roles there to look at a number of different behaviors, to be sensitive to when medications are changed versus withdrawn. It occurs to me one other issue that may be involved here is many of these medications are taken voluntarily and orally. Do you have to also be worried about a medication adherence issue? And because that, interesting enough, is also a behavioral issue, isn't it?
Oh, yeah, and it can be a huge problem. People don't like some of these medications, and so they'll slip them under their tongues and then spit them out. So, ensuring that they're used according to the treatment protocol, because if a drug's not used according to the protocol, well, you're not fairly evaluating it. And I think one thing, we shouldn't lose sight of the fact that these drugs are prescribed with certain target responses in mind, right? And if they don't change those target responses in the right direction and to a sufficient extent to solve the problem at hand, then there's no justification for their continued use. And we should never lose track of that. And one thing to keep in mind is that parents and other people who love individuals with autism want treatments to work, and they look for evidence of effectiveness. Hope is reason's greatest enemy. So even if a drug is prescribed, let's say to reduce temper tantrums, and that's really the sine qua non as to why it's being used. Even if temper tantrums don't go down, you have good data, right? The rate of temper tantrums is just the same. Well, it's easy to say, yeah, but the intensity's different. Well, you haven't measured intensity, right? But, yeah, or, well, yes, but she smiles more, right? But he seems more attentive. Well, that may be so. And if that is so, that's a good thing. However, you haven't measured that, and that's not what you hope to accomplish. And it's so easy to lie to oneself, trying to see what one wants desperately to see, and that's improvement in someone we care a lot about.
And this is a great point, actually, because, the family members are really interested in the well-being of the person in the family that's affected by autism, obviously. And what you're saying essentially is not that their input and evaluation is not important, but we need to be aware of the potential for bias seeping in there and do what you can to supplement that with either good operational definitions or with a independent evaluation from a BCBA or something of that nature. But it's still important that the parents, for example, the family members, are seeing and are happy with some of the changes, but just not stop there as the sole source of evidence for justifying medication.
Right, exactly, especially since there is risk of harm with many of these medications. And in saying that, I don't want to say that these are horrible toxic poisons that ruin everybody. They don't. But they do have a potential for harm. You know, if you take a one-a-day vitamin and it doesn't benefit you, well, you just pass it out in your urine and, you know, so you've lost a couple bucks and that's all. But with some of the psychotropic medications, they're doing something. And if it's not something good, then there's no need for people to be exposed to it.
Mm-hmm. Al, you've given us a good synopsis about the range of medications and the pros and cons of using medication with autism. You've also pointed out that it's prevalent. We have a lot of people that are using medication. And certainly parents are going to come to you as a BCBA and want to use medication or maybe ask your input on it. What do you advise the BCBAs to say to parents when they're coming and asking about medication? What is your advice to them? How do we talk to parents about medication?
Well, Wayne, the way I talk to them is just the way I've talked to you today. Mm-hmm. I don't disparage physicians. I don't argue that drugs are bad, but I do point out that the evidence of effectiveness is in many cases limited, and the evidence of long-term effectiveness is essentially non-existent. We just don't know whether a medication is going to help your son or daughter in the long run. There's no evidence that it will, but it might. Absence of evidence isn't evidence of absence. I say, you know, what do you want the drug to do? What exactly will this drug do if your son or daughter's better? And how are you going to sort out whether that happens? And also, how are you going to make sure the drug isn't producing some harm? You know, talk to the physician. What might it do that you don't want to happen? And depending on the parent, I might say, you know, why don't you go read about these drugs? And there are some good reviews that are accessible. Say, well, here's an article you could read. And if you read the good review articles, people inevitably say there is limited evidence that certain drugs are effective in treating certain conditions. There is weaker evidence that other drugs may be valuable in some regards. But then they go on to issue a cautionary statement to the effect that these drugs seem to be overused in terms of prevalence, given their documented effects, and moreover, they can be harmful. So I try to point people in that direction. If you go to the Centers for Disease Control website, for instance, or the Autism Speaks website, they have nice summaries of the effects of psychotropic drugs and how they should be used, and they're cautionary. They don't say drugs are always bad, but they say, you know, they're second-tier interventions. They don't cure autism. They may help to reduce undesired behaviors, and they may be useful for that purpose, but that seems to be about all they do. So that's the kinds of things that I tell people. As a behavior analyst, I think we have to be careful not to overstep our boundaries. You know, we aren't physicians, and physicians, I think, do the best they can. The secret is really getting the right physician. You know, it seems to me that the more a psychiatrist knows about psychotropic drugs in special populations, the more conservative she or he is with respect to the use of those drugs. The more they argue always for a data-based approach. But again, it's easy to say, well, find that kind of psychiatrist. You know, what if you're in Newberry in the UP? You know, you don't have any choice. So those are the kinds of things I tell parents.
Part of what you're saying is that sometimes parents may have unrealistic expectations of what effect drugs would have, and part of the job there is for us as BCBAs or the physicians or the parents to educate themselves about what the limits are of the drug effects. Do you think that sometimes parents pressure physicians inappropriately to do medication interventions? Because I mean, after all, those are relatively easy for the parent to implement as compared with learning to do differential reinforcement or a timeout for tantrums or something of that nature.
Sure. Yeah, no, I think unintentionally, there's a lot of pressure placed on physicians. You know, they don't have much time. Clearly, here's a family in need of help. Well, what does a physician have to give them? You know, I mean, write them a script. And moreover, when you medicalize a problem, you don't have to take any responsibility for it. I have 2 kids, and sometimes they behave well and sometimes not so well. And when they behave badly, generally I'm the cause of it. But I don't want to take credit or blame for that, you know. That's a neurotransmitter problem, right? That may be involved, but it's probably because I taught him to behave in some, not intentionally. So I think, if you can make something a disease, a medical problem, well, then it's out of your hands. And in saying that, I'm not castigating parents, but if it's and of course, the drug industry and the media has popularized this notion that our behavioral problems involve chemical imbalances. I mean, we all know that, right? Oh, too little serotonin and you're depressed. Well, that's bullshit. But yet it's been sold so effectively that everybody's, hip to the notion that brain chemistry causes us to do bad things. We can alter brain chemistry with a pill that's sweet and easy and it solves everything. But that's just not true. So,
well, you make an interesting observation, and that is the degree to which the media and the pharmaceutical industry has gone directly to the patients, the consumers, with all the advertisement that show up on TV. I'm a little surprised I haven't seen anything, maybe they're out there, but advertisements for parents of children on the autism spectrum, marketing drug treatment essentially to correct imbalances or something of that nature. It may be just a matter of time before that happens.
Well,
it's
illegal. Drug houses can't market drugs for off-label indications. However, they do it. You've probably heard about the problems that have beset Johnson & Johnson. They are the manufacturers of Risperdal. And they aggressively marketed Risperdal to physicians for off-label use, first in children, and it's not approved for use in children. And then once they kind of drunk that well dry, they started aggressively courting physicians to use Risperdal off-label for senior citizens. And both of those applications are inappropriate. There's no evidence that Risperdal is useful, and that they've gotten into a lot of trouble for that.
But they've probably also made a lot of money for it, haven't they?
Oh, sure. Yeah, exactly.
Right. Interesting.
Exactly.
Yeah, it is interesting to see where the marketing goes once again directly at the consumers as opposed to the physicians who may be in a better position to evaluate the marketing and the claims, that sort of thing.
Exactly.
Yeah, very good. Al, we've talked about a lot of things in terms of where we are with drug treatment of autism, and it sounds like we're in a very changing environment, things that are hopefully emerging. Can you look down the road? I know that forecasting the future is prone to all kind of problems, but where would you like to see us be a decade from now? What do you think's on the horizon, and where would you like to see our pharmacological approach go in a decade or so from now, Al?
I may be cynical by nature, but I fear, Wayne, we'll be the same place 10 years from now that we are today. 30 years ago, 35 years ago, I became interested in the effects of psychotropic drugs in people with developmental disabilities, primarily mental retardation in those days. And the situation was the same at that time and over time thereafter, as it is now with respect to the use of drugs in people with autism. And the situation was this. The evidence for effectiveness was limited and weak, but the drugs were widely used. Many people were sounding cautionary notes. but nothing changed. Widespread, nothing changed. In pockets, it did change. And people started, physicians, psychiatrists, especially research psychiatrists, came to be more conservative in their use, in part because there were some lawsuits. People claimed that they were damaged by these medications without offsetting benefits. And that led to a decline in the prevalence of drug use in people with mental retardation. Something like that might happen with respect to the use of psychotropic drugs in people with autism, but I hope not. I hope we don't have to have people injured before we come to be more conservative and more data-based. And I'd really like to see us move more toward a team approach where people with different specialties offer to people with autism simultaneously the tools at their disposal. You know, we shouldn't deprive people of psychotropic drugs. They can be hugely useful. On the other hand, giving them widely with the notion that one size fits all is ruinous. So if we could have the kind of teams we've talked a little bit about, I think that would be ideal.
Mm-hmm. Does the emergence of BCBAs as part of the equation offer you any glimmer of optimism, you think, Al, in particular in terms of the skills we may have in doing behavior assessments and helping do clinical progress monitoring?
Well, I think it certainly offers us a foundation upon which we can build. You mentioned earlier the silos in the medical research and the behavior analytic research. I fear that there are silos just between the disciplines. You know, I mean, everybody has their vested interests, and you know, at least historically, we haven't been very successful in working with physicians across the board. I mean, there are certainly cases where, you know, there are excellent teams, and I'd like to see us move more toward that. Maybe there's some other way to do it too. I mean, maybe you could have nurse practitioners doing the prescribing of these drugs, or physician's assistants, or even psychologists. You know, there's some years ago there was a bit of a movement to allow limited prescribing privileges for psychologists. That seems to kind of have fallen by the wayside, but you know, maybe that would be a way to do a little better evaluation of the effects of these drugs. But honestly, I don't see any of these things happening, but I could be wrong.
Well, let's hope that we continue to do some sort of evaluation, and we continue to maybe improve the pharmacopoeia and make it more precise as we're going along, if nothing else.
Well, you know, one maybe parting message is, for sure we're going to make it bigger. You know, because people are, I mean, this is a lucrative market. And that's one reason people are hoping to develop other drugs. But also, you know, people want drugs that will be useful in treating the core features of autism. And I mean, I hope they find one. I mean, I would love for someone to find a drug that works so well in treating people with autism that all of us behavior analysts were out of business. That's not going to happen, or I doubt that it'll happen. But, you know, were it to happen, that would be wonderful. That'd be the miracle we all hope to effect. But till we get that miracle, I think the best we can do is, you know, to work hard every day and put our best practices in place and make sure that they're effective.
With that, Al, thank you very much for kind of the synopsis of what you see as our current challenges and future challenges as it pertains to pharmacological management in the autism spectrum. This is an important topic for not only the parents and the families, but also for the BCBAs, and I really appreciate your insight and guidance in this particular area. Thank you.
Oh, thank you, Wayne. It was my pleasure.